Following is a presentation on our approach to abdominal plain films and has been prepared by Deborah Silver under the supervision of Dr. N. Jaffer. Throughout the presentation, please click on the small abdominal X-ray in the lower right corner in order to proceed to the next slide. The objectives of this interactive presentation are to give an introduction to reading abdominal plain films, to review basic abdominal anatomy, and to give a basic approach to interpretation of abdominal X-rays. Abdominal plain films have limited usefulness with the advent of new imaging technologies, such as CT and ultrasound. However, plain films are a particularly useful and inexpensive imaging modality for the diagnosis of some conditions. In an acute situation, signs of bowel perforation, toxic megacolon, bowel ischemia, and both small and large bowel obstruction can be seen on a plain film of the abdomen. Signs of more chronic conditions, such as constipation and calcifications, can also be seen. The radiographic findings for these conditions will be covered in more detail throughout the presentation. Please note that abdominal plain films have little utility in diagnosis of GI bleed, chronic anemia, and vague gastrointestinal symptoms. The anterior-posterior radiograph, in which the X-rays are passed from front to back, is most commonly done to image the abdomen. This type of radiograph can be done in the upright position with the patient standing, in the lateral decubitus position with the patient lying on his or her side, or in the supine position with the patient lying flat, as demonstrated in the images on the left. An upright radiograph shown in the top image is particularly useful in searching for free intraperitoneal air and intestinal air fluid levels. If the patient cannot stand, a decubitus radiograph shown in the middle image can be substituted. When viewing the abdomen, it is important to remember that it is divided into two cavities, the peritoneal cavity and the retroperitoneal cavity. The peritoneal cavity is lined by a layer of tissue called the peritoneum, which wraps around most of the bowel, the spleen, and most of the liver. The peritoneum forms recesses called pericolic gutters between the lateral aspect of the ascending or descending colon and the abdominal wall. Free fluid in the abdomen can accumulate in these gutters. The second cavity, retroperitoneal cavity, is found behind the peritoneal cavity, and it contains the second, third, and fourth parts of the duodenum, the ascending and descending colon, the rectum, the kidneys, the ureters, the bladder, the adrenal glands, the psoas muscles, the abdominal aorta, and the pancreas. Please note that the pancreas cannot be seen on plain films. This slide reviews the anatomy of both the small and large bowel. The small bowel is composed of the duodenum, the jejunum, and the ileum. The large bowel consists of the appendix, cecum, ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, and rectum. Please click on the blue text to view selected structures in the bowel. The following images have the paths of both the large and small bowel outlined in blue. As shown in the image on the right, the small bowel is located in the middle of the abdomen. The image on the left shows the path of the large bowel, which is located around the periphery of the abdomen. The inner part of the bowel that contains air can be visualized. However, under normal circumstances, the outer limits of the bowel wall are impossible to see as they are of fluid density. There are some morphological differences that enable us to differentiate small and large bowel on plain films. The location of each bowel type differs, as the small bowel is located centrally and the large bowel is located peripherally and takes the form of a picture frame. The small and large bowel can also be distinguished most easily when dilated by their different mucosal markings. The small bowel has folds called plicae circulares, which cross the entire bowel width, whereas the large bowel has folds called haustra, which do not cross the entire bowel width. The small and large bowel also differ in diameter. A normal small bowel should measure less than 3 centimeters in diameter. The large bowel should have a diameter of less than 6 centimeters, except for the cecum, which should have a diameter of less than 9 centimeters. Fecal content is uncommonly seen in the small bowel, but it is usually seen in the large bowel. Fecal matter is seen as a mixture of gray densities representing a gas-liquid-solid mixture. This slide outlines the anatomy of the genitourinary system and other structures seen in the abdomen, including the psoas muscles and the bones. The genitourinary system is comprised of retroperitoneal organs, including the kidneys, the ureters, the bladder, and the adrenals. Please click on the blue links to view the corresponding anatomy. There are several steps in the basic approach to abdominal X-rays. First, a proper history and physical must be done prior to radiographic study. In addition, the possibility of pregnancy in women of childbearing age should be determined prior to obtaining an X-ray to avoid unnecessary radiation to a fetus. Second, in reading the radiograph, use labels and markers to ensure that the radiograph is positioned properly and establish the projection and position of the film. Also, check that the film is for the correct patient. Third, always look to see whether old films are available for comparison. Lastly, ensure that the film quality is adequate in terms of completeness and exposure. In order to remember the approach to abdominal plain films, remember the mnemonic, free abdo. The free stands for free fluid, the A stands for air, the B stands for bowel wall thickening, and the D stands for densities and calcifications, and the O stands for organs. Free fluid in the peritoneal cavity can originate from a variety of different sources and varies greatly in composition. The fluid may be transudative, exudative blood, or bile. It is not possible to differentiate between different types of fluid on plain films. In order to detect free fluid on a plain film, at least 500 cc of fluid must be present. There are different findings on abdominal plain films depending on the amount of fluid present. As seen in the plain film shown on the right, bowel may pool in the center of the abdomen where there are larger amounts of free fluid in the abdominal cavity. In addition, there may be increased opacification on the abdominal plain film if larger amounts of fluid are present. Different radiographic findings occur when smaller amounts of free fluid have accumulated. When smaller amounts of free fluid are present, the distance between the colon and the flank fat stripe may be increased. If this distance is greater than 1 centimeter, there is likely free fluid in the paracolic gutter. Note the distance between the bowel and the flank fat stripe is increased on the plain film shown, indicated by area highlighted in the blue. The CT scan shown on the right also demonstrates this finding as indicated by the arrow. The interpretation of plain abdominal films routinely includes an assessment of air. When examining an abdominal plain film for air, one must consider that air can be intraluminal or extraluminal. Start by looking at the amount and distribution of air in the GI tract and examine the bowel lumen size and distribution of bowel loops. Dilated bowel can result from a variety of different processes. A dynamic ileus occurs when there is stasis of bowel contents due to decreased or absent peristalsis. As a result, gas builds up in the GI tract and diffuse symmetric distension of bowel occurs. Toxic megacolon, as shown in the film in the bottom left corner, is a type of ileus that is characterized by extreme dilation of all or a portion of the colon. Peristalsis is absent and the large bowel loses all tone and contractility. The diagnosis is suggested when the diameter of the colon exceeds 6.5 centimeters and the mucosa appears abnormal. This includes ulceration, pseudopolyps, and loss of hostration. If perforation occurs, evidence of pneumoperitoneum may be seen. These findings will be discussed later in the presentation. Symptomatically, the patient has progressive abdominal distension and is toxic and obtunded. Toxic megacolon must be dealt with urgently as mortality approaches 20%. The most common cause of toxic megacolon is acute ulcerative colitis. Another major cause of increased intraluminal air is bowel obstruction. As plain films are only a diagnostic in approximately 50% of cases of bowel obstruction, CT is the imaging method of choice when the diagnosis is equivocal. The etiology of the bowel obstruction is not identifiable on plain films except in cases of large bowel volvulus, hernia, and gallstone ileus. When a bowel obstruction occurs, the bowel lumen proximal to the obstruction dilates due to secretions, swallowed air, food, and cessation of absorption, and the distal lumen collapses. Small and large bowel obstruction can be differentiated by several characteristics seen on plain film. These differences are outlined in the chart displayed below. The image on the left shows the step-ladder pattern seen in small bowel obstruction. Each step is a separate air fluid level. Air fluid levels at differing heights within the same bowel loop are strong evidence of obstruction. The image on the right shows a string of pearls sign also seen in small bowel obstruction. This results from small bubbles of gas trapped between folds in dilated fluid-filled bowel loops. As the management differs for ileus and bowel obstruction, it is important to be able to differentiate between these two conditions. A diagnosis of bowel obstruction is suggested when the plain film shows differential air fluid levels, dilated bowel, lack of air beyond obstructed segment, string of pearls sign, stepladder pattern, or a gasless abdomen. If the patient's symptoms are due to ileus, suggestive findings include air throughout the GI tract, a normal caliber bowel, and air fluid levels will be on the same plane. The plain film on the left shows findings indicative of a bowel obstruction. Some of the features just highlighted, including differential air fluid levels and dilated bowel, can be seen on the radiograph. The image on the right shows the findings of an ileus. Notice that there is air throughout the bowel and there is no differential air fluid levels. Volvulus is a specific cause of bowel obstruction. A sigmoid volvulus occurs when the sigmoid colon twists around its mesentery. On plain films, the sigmoid colon appears as a large gas-filled loop without haustral markings, arising from the pelvis and extending high into the abdomen. This is referred to as the coffee bean sign seen in the image below. If a volvulus occurs in the cecum, plain films will demonstrate a massively dilated bowel loop projecting into the left middle or upper abdomen. In addition, the small bowel will be distended and the distal colon will be decompressed. Normally there is no air outside the GI tract. When air escapes from the bowel lumen, it can be seen in the peritoneal space, the retroperitoneal space, the bowel wall, the portal veins, the biliary tree, or within organs. The next few slides will provide further detail about these situations involving extraluminal air. Free air within the peritoneal cavity is a valuable sign of bowel perforation. Major causes include duodenal or gastric ulcer perforation, trauma, recent surgery, or infection with gas-producing organisms. Post-operative pneumoperitoneum usually resolves in a few days and is not a cause for concern. Two findings that may be seen include air under the diaphragm and Wriggler's sign. It is easier to see air under the right diaphragm as the gastric air bubble may make it more difficult to see air on the left side. An upright view is best to see air under the diaphragm. Note the air beneath the diaphragm on the plain film shown on the left. In Wriggler's sign, gas can be seen on both sides of the bowel wall. The sign is most easily seen on a supine view of the abdomen. The radiograph on the right demonstrates Wriggler's sign as indicated by the arrow. Extraluminal air can also be from a retroperitoneal source. If the abdominal structure that perforates is retroperitoneal, this will result in free retroperitoneal air. When this occurs, retroperitoneal structures may appear outlined by air, and streaks of air may be observed. Please note the appearance of air outlining the psoas muscles, the kidneys, and the cecum in the plain film shown. Another condition involving extraluminal air is pneumatosis intestinalis. It occurs when gas is present in the bowel wall. The most common and most emergent life-threatening cause of intramural bowel gas is bowel necrosis due to bowel ischemia, infarction, necrotizing enterocolitis, volvulus, or sepsis. Other causes include steroid and immunosuppressive drugs, collagen diseases, and benign idiopathic pneumatosis. Note the linear black streaky appearance in the bowel wall in the plain film shown, indicative of pneumatosis intestinalis. Portal venous air occurs when the intraluminal gas found in the intestine or produced by bacteria enters the portal mesenteric circulation. If present, a dark branching pattern is seen throughout the liver, including the periphery. Please note this finding on the radiograph shown on the right. The appearance arises from the accumulation of gas in the distal portal system, which is carried by the flow in the portal vein. The etiology of this finding can be due to ischemic causes and non-ischemic causes including sepsis, colon cancer, inflammatory bowel disease, trauma, and iatrogenic causes. Ischemic causes are the most common and have a worse prognosis. Portal venous air is most often pathological and frequently fatal. Pneumobilia refers to air in the biliary tree. As a result of the direction of bile flow towards the hilum of the liver, pneumobilia has the appearance of dark branching structures at the hilum. It is most often the result of bile duct manipulation such as sphincterotomy. Other causes include gallstone ileus, peptic ulcer, cholangitis, emphysematis, cholecystitis, and fistula. Note the dark branching pattern in the area of the hilum seen on the radiograph. It is also important to look for any bowel wall thickening on abdominal plain films. When bowel wall thickening occurs, both thickening of the bowel folds occurs and narrowing of the bowel lumen as well. As a result, it may appear that there is also increased distance between bowel loops as well. On plain films, the large bowel appears as though it has been indented by a thumb, and this is referred to as thumb printing. When this phenomenon occurs in small bowel, it is called pinky printing. The most common causes are inflammation and ischemia. Every thorough examination of an abdominal plain film also includes an assessment of bones and other calcifications that may be present. Calcifications are the most radiopaque of any natural substance on plain film. Calcium can be seen in normal and abnormal structures. Abnormal calcification can be indicative of underlying pathology, but calcification can also be the pathology itself. Normal calcifications include costal cartilage, pelvic vein febrilis, the prostate gland, and mesenteric lymph nodes. Both febrilis and lymph nodes can be difficult to differentiate from kidney calculi. Calcium can indicate pathology when seen in certain locations. Calcification in the pancreas is most frequently a sign of chronic pancreatitis. Calcification in the renal parenchymal tissue is indicative of pathology including renal tubular acidosis and hyperparathyroidism. Calcification of blood vessels can occur at various locations, and if it is extensive, there may be an underlying atheromatous process within the arteries. Fibroids can also become calcified. Finally, calcification is itself the pathology in cases of biliary calculi, renal calculi, appendicolith, bladder calculi, and teratomas. A finding of abdominal calcification on a plain film should be confirmed by a CT or ultrasound. Of all of these calcification types, plain films are the most useful for detecting renal stones. Alternate imaging modalities are used to look at organs and soft tissue, as the visualization of organs and pathologies within them on plain films is poor. For example, the plain film shown on the left appears normal, but the two abdominal CT scans of the same patient shown on the right reveal multiple liver and kidney cysts. In summary, plain films are used mostly for detecting bowel obstruction and perforation. The AP upright view is the most useful for detecting free air and air fluid levels. One should look for both intraluminal and extraluminal air on plain films, and extraluminal air is usually pathological. Calcification may be normal, may indicate pathology, or may be the pathology itself. Therefore, radiographic findings must be correlated with the clinical scenario. Plain films are not recommended for examining abdominal organs and soft tissues. There are 3 supplemental cases provided to reinforce what you have learned throughout this presentation. As you go through the cases, please click on the blue text in order to see the correct diagnosis.